Alrighty. Okay, so now we're going to talk a little bit about renal and bladder ultrasound. Another one of the really common indications that you might be using the ultrasound machine in the emergency department. So topics that we're going to cover. So there's a huge amount of pathology one might see. We're going to again take a really broad view, talk about some of the most common things that we might be looking for, some of the most common things we might see. So we're going to talk a little bit about what the bladder and the kidneys normally look like. We're going to talk about measuring bladder volume using the ultrasound machine. We're going to talk about hydronephrosis and how to assess for hydronephrosis and grade hydronephrosis using an ultrasound. And then we're going to talk about renal stones because this might be one of the particular things that you're interested in assessing for. And then I threw in a couple of extra slides because there are some things that you might see that you maybe weren't looking for. And it's nice to know what they are and what they might mean. We obviously can't cover every one of those scenarios, but there's a couple, I think, of key images that we can talk about. So, all right. So for this one, the probe you're most frequently going to be using, and the default probe for both bladder and renal ultrasound is going to be the curvilinear probe. Okay. So let's talk first about the normal anatomy. So the normal anatomy of the bladder. Okay. So this is transverse on the patient. So if this is my probe, this is essentially going to be like so, okay? And scanning right across the bladder, okay? A nice fan through gives you a good sense of the entire bladder from the most superior to the most inferior aspects, okay? In order to get a full ultrasound view of the bladder, you also do a sagittal view, okay? So that would be like so on the patient, okay? So this being my probe, like so. All right, and again, what we're seeing, the bladder here is the large hypoechoic, so dark structure because it's full of fluid, okay? And we can see here in this trans view, we also see the pubic symphysis, and we can see as well that there's a uterus nearby as well. Okay. Another thing that you may notice when you're looking at a bladder is that if you put on color Doppler, so the color Doppler, which is essentially looking for fluid moving towards the probe or away from the probe, if you put on color Doppler, one of the things that you will notice is that there will be these intermittent ureteral jets. And that is normal anatomy. You expect that on occasion, urine is going to come out of the ureter into the bladder, and that we should be able to appreciate that by using our ultrasound machine. Okay, so this is a normal feature. If you were to put on the color Doppler, you expect this to happen. And if you wait long enough, you expect that it should be on both sides and about equivalent in strength on both sides. Okay, let's talk now about the kidney. So I believe that you all have already seen the kidney in the FAST exam. Talked about the right upper quadrant and left upper quadrant views. Effectively, the positioning of the probe in order to see the kidneys is very, very similar. The only difference being that instead of doing just a long version or a long assessment of the kidney, we're also going to do a short axis view of the kidney. So essentially turning the probe 90 degrees. So long axis, short axis. A couple of good tips for looking at the kidneys is that the left kidney tends to be further posterior and further superior. So further towards the bed, further towards the head than the right kidney. The teaching is that the right kidney tends to be best viewed along the mid-axillary line, whereas the left kidney usually is the posterior axillary line in order to get good views of it. There's always an issue with rib shadowing, and so rotation of the probe in order to find optimal windows is important. Okay, as we're looking at this, we notice that to the left side of the screen is going to be towards the head, that's superior. And we know that this is a left kidney, partially because it's labeled here on our machine, but also that we can see that this, the organ sitting superior to it has architecture consistent with the spleen. So this is a left kidney, and we see that this is a kidney where we don't notice any dilation in the pelvis of the kidney, and we don't see that the calyces are blown out or that the cortex seems to be misshapen. That'll all come back here in a little bit. So another view here of the kidney with it highlighted so that you can kind of see its anatomy there. All right. And so cortex and calyces in that bluish color, and then in pink is the pelvis of the kidney. All right, again, that's that left side. Okay. One of the things that you can do is, again, we talked a little bit about Doppler, on what Doppler will look like when you use it on the bladder that we expect urethral jets. One of the things that's useful when you're looking at a kidney and you can't quite tell what's going on, whether, maybe there is a little bit of hydronephrosis, which we're going to cover in a moment, or maybe not, and you're kind of unsure. It's actually very helpful to then put Doppler on. If it's hydro, it really shouldn't show up under Doppler because hydro is not moving back and forth. Hydro is static. It's stagnant urine dilating the kidney. However, if you put the Doppler on and you do get this Doppler signal that it shows up as color, that is indicative that these are just prominent vessels within the kidney and that this is just blood flow because it is moving. Okay, so this is actually a normal kidney, even though on that left side it's a little unclear. You wonder if this is hydro. When you then put on the color, no, these are just prominent blood vessels. Okay, so let's start with probably one of the most common, but also nicely one of the most simple of our indications for using the ultrasound for kind of a renal bladder is just measuring bladder volume. So this is a pretty simple mechanism. So we remember that we have these two views of the bladder, which we already looked at. These are those two views just put side by side. And most machines will have an ability to calculate within the machine, but there's a simple, just kind of poor man's way of doing this, which is you just take every axis of the bladder, which is why you need two orthogonal views, and then multiply them together so that you have a volume. This is a rough calculation, but approximately correct. And then there's some dependence on age, but somewhere under 100 cc's of urine post-void is considered normal in virtually everybody. Older people tend to hold on to a little more urine, and really young people or children tend to hold on to a little bit less, but I use as a round number I can remember somewhere around 100. All right, let's talk about hydro. Hydro requires a little more interpretive art as you're looking at it. But let's say that you have someone and you're concerned about urinary retention. Let's say that they have signs that are concerning for a stone, or let's say that you have already used your ultrasound and diagnosed the fact that they have urinary retention. They have 1.5 liters of urine in their bladder, and now you want to know, do they have hydro from this? Do they have structural signs of kidney damage by ultrasound? That's something that we can assess for. So hydronephrosis has grades, which are usually referred to as being 1 through 4. Sometimes you'll see a grade 0 referred to, and grade 0 just means normal architecture. So the ones that we've been looking at are grade 0, no hydro. You'll also hear people, instead of using the numbers, say mild, moderate, and severe. And this is kind of the general sense of overlap. So the way that I think about this is that the first stage of hydro is dilation that is affecting the pelvis. The second stage of dilation goes into the major calyces. The third stage of hydro involves major and minor calyces. And then the fourth stage is going to actually disrupt the cortical structure. So you actually see thinning of the parenchyma of the kidney because it's being compressed so severely by the urine. So essentially pelvis, major calyces, minor calyces, and then parenchyma. Those are the structures that are affected as you go 1 through 4. So let's look at a couple of actual ultrasound images of this same concept. Okay, so here we're seeing a minor amount of hydro. So why is it, do you all see does my arrow show up on your screen? Yeah, it does. Okay, so great. So we can see here in the pelvis that we're starting to get some dilation there, that we actually are seeing that hypoechoic structure indicating that urine within the renal pelvis is starting to accumulate. So that's a mild hydronephrosis. I would say even early mild. So now this is a moderate. So I would call this probably a stage 2. And you're seeing that not only here in the pelvis, but we see it extending now into the calyces, the major calyces. And so we see more disruption of the normal architecture of the kidney that we saw earlier. Continuing in increasing severity. So this is a stage 3, also a moderate hydronephrosis. But you can see now that not only do you have the pelvis involved and the major calyces, but you have this general kind of rounding out that tells you that the minor calyces are also involved. However, we know that this is not severe, and we're about to look at severe, but we know this isn't severe because you still see this nice thick cortex to the kidney here that indicates that this is still a moderate rather than a severe hydronephrosis. This is a particularly cool image. You can see it's already labeled, but you can also see why this person has hydro, that they have this big old stone sitting right at the ureteropelvic junction. So this is kind of your like all-encompassing diagnostics. We'll talk about stones again here in just a moment. But so this is another moderate hydronephrosis. We're calling this grade 3. All right, this is what severe hydronephrosis looks like, right? So you can tell that, if you were to just be given this image, you might not even be able to initially tell that it's a kidney because the entire architecture of the kidney has been changed by the amount of dilation. You can see here that there's thinning of that cortex. This is severe organ damage from urine backup. So this is severe. This is grade 4 hydronephrosis. Okay, so let's talk about stones. One of the stones can be detected by ultrasound, but because of limitations to the anatomy that can be easily assessed by ultrasound, not all stones will be seen while doing an ultrasound, which is important to know. If someone has signs of renal colic, but you don't see a stone on ultrasound, it does not mean that they don't have a stone. It may just mean that it's too small to be readily diagnosed by bedside ultrasound, or it may be that it's in an anatomic location somewhere along the ureter that's not really well visualized. However, there are multiple common positions for stones to get lodged that are well visualized on ultrasound, and so it's useful to know, and especially nice to know if you're wondering what's going on and then you see a stone. It is a very diagnostically helpful tool. So here we see something somewhat similar to that prior ultrasound. So right there at the ureteropelvic junction, once again, we see this hyperechoic structure. It's got some posterior acoustic shadowing. And that is a stone lodged at that area. For context, if I'm remembering correctly, this stone was about a 7mm stone. So it's a relatively large stone to be able to be seen this well. in terms of hydronephrosis, you can see that this person has, you know, a little dilation here in the pelvis, and probably some extension up into the calyces. They're kind of on that mild to moderate spectrum in terms of the amount of hydro they've got. Some of the views look pretty normal, but a couple of that fan through view right there at the very beginning demonstrates that there is urine tracking further up pelvis, up into calyces. So this person is experiencing some hydronephrosis from this large stone. Okay. Another place that you might find stones is right as they're about to get into the bladder. So this is actually 2 stones in this really unlucky person, sitting right at the ureterovesicular junction. So you can see these 2 honestly big honking stones ready to go into the bladder. Again, how do you know that they're stones? They have this very hyperechoic, bright appearance, and then this is a really nice example of that posterior shadowing, where you see that the sound waves hit the stone, but then they can't travel down past the stone, and so you get this kind of V'ing out as the sound of the area that the sound waves are not reaching. So this is another common place where you might find stones, and is a place that is well visualized by ultrasound. One of the other things that you might see, because we've talked a little bit about the uses of Doppler in renal and bladder ultrasound, is this thing called the twinkle sign. So you might be looking at a structure and wondering, you know, what is that? Is that a calcified lymph node? Is that a stone? What am I looking at? This is what's called the twinkle sign, and this is just when you place the Doppler on a stone, and this is most commonly done here at the UVJ. You'll see this kind of little flashing of red and blue, and what that is urine right behind the stone is kind of pushing against it and is therefore kind of creating a little bit of a hydraulic and swirling, and so it shows up as fluid coming towards and away and towards and away and towards and away to the ultrasound. And that is an indication usually of blockage behind a stone. This is a known entity, the twinkle sign, that will be behind stones, particularly visible here at the UVJ. You may also see large stones in the bladder. There are multiple things that might show up in the bladder, but one of the reasons that you suspect that this is stone when you see it is that this is a rock. I mean, this person has a boulder living in their bladder, but you see that posterior acoustic shadow letting you know that this is something dense that's not letting sound waves through. This is a person with a really large bladder stone. Okay. I mentioned that there's a lot of things that you may encounter when you are doing renal and bladder ultrasound that I wanted to take a look at. These are not necessarily things that you're looking for, but that you may incidentally find. So renal cysts are relatively common. It's likely that you'll see some just when doing FAST exams. And if you start doing renal ultrasound as well, you'll find a number of people who will just have these extremely well circumscribed, usually very circular, hypoechoic, dark structures that are within the cortex of the kidney. You've probably seen them on CT scan as well. But this is a simple renal cyst. This is typically not a pathological finding. It's something I tell patients that they have, but it does not necessarily mean anything pathological. It's, from the emergency department's standpoint, just something for the patient to know about and perhaps follow up on. But that a single renal cyst is usually an incidental finding, but one that you will find relatively commonly. This is what it looks like if someone has polycystic kidney disease. Honestly, the few times that I have had patients who have polycystic kidney disease, it's actually kind of nice to do an ultrasound if you have an indication to, just to understand what it looks like. And you can see, just rather than that one simple cyst, you have them all over. They're of different sizes. It doesn't really look like hydro, while the initial impression might be, oh, is this hydro? If you kind of go back to the principles of where the hydro starts and then how it spreads out, it doesn't really look like hydro, right? There's not dilation specifically to the pelvis and then extending out. The cortex is actually spared. You don't see that it's thinned. These are just essentially a bunch of pock marks through the kidney that are not related to urine. This is another finding that you're likely to see if you're doing exams because of urinary retention, hematuria, anything like that. So in this view of the bladder, so this is a sagittal view of the bladder, and what we see is that there is something in the bladder. Of the things that can be in the bladder, we've already seen a bladder stone. This doesn't have that kind of shadowing. You can see sediment or blood if that happens to be in the bladder. But we don't see this swirling. And what we see is that this is attached to the wall. This is consistent with bladder cancer, unfortunately. So this is, while this is not a diagnostic image, it's a really, really suggestive image of a neoplasm in the bladder. And then this is another thing that at some point you may run into, especially in folks who have urinary retention or problems with catheters, is bladder diverticula. If you think you see more than one bladder, the first question I would ask myself is that actually free fluid outside of the bladder? Like, does this person have blood in their belly? But then if the answer is no, if you are looking at your images and that doesn't seem consistent with your images, oftentimes it's just that the bladder has an outpouching. And you can see that it can be really, really impressive under ultrasound. And this person has wisely put Doppler on there so that they can see actually urine communicating between the two portions of the bladder, demonstrating that they are contiguous. So this is just bladder diverticula. Okay, so I have, again, a couple slides. If you all just want to talk about what you see on these slides, we can go from there. All right, so first slide. What is this? I'm sorry, I couldn't quite hear.
The kidneys, so that looks like dilated renal
Yeah, so this person has got some hydronephrosis.
Yeah.
We're saying that you see a stone.
Yeah, right at the there.
Let's see. So I'll be honest, I am not seeing a stone, but that doesn't mean that it's absolutely not there. I mean, this person has hydro for some reason. I put this on here as a demonstration of hydronephrosis. Let's talk about what grade of hydronephrosis is this? Is this, and we can, instead of using the 4, 1, 2, 3, 4, let's say, is this mild, is this moderate, or is this severe?
Moderate.
I would say moderate.
The renal pelvis, and then it's sort of extending towards the calyces. So
yeah, I agree. I would say exactly the same thing. The pelvis is definitely dilated, and it looks like the calyces are also dilated. I would definitely call this a moderate hydronephrosis. I think now that you're saying it, I think I am seeing what you're seeing. I'm not positive whether that's a stone.
That's close to the end.
I'm going to look back at the source image and see, but that's a great catch if that's what that is. Yeah. All right, we'll move on to the next one. All right, so what's wrong here? What are we looking at and what is wrong?
That's a bladder. And IDC. Yeah, catheters.
Yeah, exactly. So it's a bladder with a Foley catheter in it. That's what a Foley looks like on ultrasound. What is weird about, what is unusual about seeing the bladder and a Foley catheter in this way?
It's gone to It looks like it's sort of adhered to the wall.
Yeah, exactly. So there has to be some sort of problem because the Foley should be draining sufficiently that there shouldn't be that much urine in the bladder. So clearly something's wrong with the Foley. This particular clip is actually that the Foley has passed through the bladder into a diverticulum and is therefore not working. And so what this clip is that they've actually deflated the balloon, pulled it back, and then replaced it into the bladder. It's a pretty complicated one, but that's exactly right. I mean, the key things are you're seeing a Foley, you're seeing a bladder, and then you're noticing that there has to be something wrong because there's urine in the bladder when there's a Foley there's something not working. Okay. All right. Yeah, so I will tell you that this clip is a kidney.
Oh, yeah, severe hydronephrosis.
Yeah. So essentially, I mean, I would say that, like I said about severe, if you were to pull up a clip, if you were to see an image and not know where the probe was on the body, it can be hard to tell what you're looking at because we have this image of what a kidney should look like. The kidney on ultrasound looks like a kidney. But if you have severe hydro, all of a sudden, all bets are off because it just no longer has the same architecture as the organ.
Yeah.
So yeah, severe hydronephrosis, exactly. Okay. And then what are we looking at here?
Looks like so it's a Doppler looking at the bladder.
Yeah, so did I hear bladder? Yeah, so bladder. It's labeled as jet. So jet just means the ureteral jet. Okay. And so we remember that the ureteral jets should be both sides and about equal in intensity. So we can see that on this particular patient, on the right side of the screen, we see this really strong ureteral jet. On the left side, there really isn't a strong ureteral jet, certainly not of the same magnitude as there is on the right side. And what we do see is that posterior to where we expect for there to be ureteral jet, we kind of get this twinkling. We get some on the Doppler. So this is indicative that this person probably has a left-sided stone right at the ureteral vesicular junction. Okay, so because of only one jet, and then we also have the other clue, which is the twinkle sign. This is highly suggestive of a stone right in that area. Okay, does that make sense? These are pretty. This version was relatively advanced ultrasounds to follow up like 15-minute lecture. So that was great. That was absolutely phenomenal. Okay, what about this one?
It's the kidney.
So it doesn't look. Yeah. I can't really see any dilated renal pelvis, but those look like more like small cystic lesions.
Yeah. So do you see anything at the periphery of the kidney?
Periphery. So hyperechoic.
Yeah. So I'm seeing the same thing you're seeing. Are you talking about this? Yeah. So I would agree. So there is something hyperechoic there, and position wise, that is suggestive of being right at the ureteropelvic junction. That's right where that is. So if this person were having symptoms consistent with renal colic, I would say that's a stone. In terms of the question about hydro, you mentioned cystic lesion. So I think you're talking about all these things up here, right? Okay. So this is one of the subtleties of renal ultrasound, and there's a certain amount, honestly, of provider interpretation that goes on here. But these are not necessarily abnormal. Some people have more pronounced calyces than others. And if you were to just do ultrasounds on a huge number of people, you would see some variation. And some people just, it looks more, you just can see the calyces better. One of the indications that they are not truly dilated is that you can see that individually they still taper down towards the pelvis, and that they're separated.
Yeah.
That indicates that they're not necessarily involved in a hydronephrosis process. I will say that one clip right here towards the beginning, towards the beginning makes me kind of say maybe this person does have a little bit of dilation. It looks like that pelvis right in here has got a little extra fluid, maybe even like a little bit of tracking towards the major calyces. But I would probably, if I were to be the scanner on this one, I'd probably say this person has mild hydro and a stone. That probably would be my interpretation.
Right.
But this is like a nice kind of like putting it all together, understanding, what's normal, what's not normal, hydro and a stone. I mean, this is I think one of the situations, one of the clinical scenarios in which this can be a really, really useful tool. Because if you had somebody who it looks like is having a kidney stone, and you were to have this ultrasound, it'd be very diagnostic. You've seen a stone, you've seen that they have mild hydro, which is not necessarily dangerous. You expect a small amount of hydro with a lot of stones. If they're having moderate to severe, of course, mild doesn't necessarily make me too worried. And their labs and their urinalysis looks okay. You have a pretty complete diagnostic picture at that point. Okay. Any questions for me about that? That was like a fly through of a number of pretty advanced topics in renal and bladder ultrasound. What questions do you have? There's a lot there. And
just a quick question about for example, trying to look for not free fluid, but in cases of trauma or even renal abscess. So those appearances, would it be not easier, but would it be more defined to see it on ultrasound scan?
Yeah. So thinking first about trauma, and then about renal abscess. So in terms of trauma, your standard exam. Do I understand? Have you all already had talk about FAST and EFAST exams? Is that something you all are already familiar with?
So we've been doing a lot of individual reading.
Gotcha.
Around it, but no formal.
Yeah. So in the case of trauma, it can be. So I would say that the ultrasound is really useful for detecting blood within the peritoneal cavity, as long as it gets to somewhere around 500 mLs of blood. Right, that tends to be approximately your cutoff of being able to reliably see it on ultrasound. And what you see in that case is a hypoechoic, a dark stripe that will be outside of the kidneys. Specifically, it's going to be right upper quadrant sitting between the liver and the kidney is usually your first positive view on the FAST exam. That tends to be the first place that enough blood has accumulated. And so again, but that is outside of the kidney. It's literally like a layer of fluid sitting between those two organs. On the left side, a positive view will usually will sometimes be sitting between the kidney and the spleen, but actually frequently you'll actually see it coming up over the top of the spleen. It's not, and it tends to happen later than it does on the right side. In terms of direct trauma to the kidney, ultrasound is not a reliable way to tell if someone has solid organ damage to the kidney. Really severe, high-grade parenchymal damage might be visible, but if the capsule of the kidney is not actually violated, you won't necessarily be able to diagnose it by ultrasound. That's not an established use of the ultrasound. If it's really bad, you still might see. I mean, the architecture might just be really off. But it's really once blood gets into the peritoneal cavity that the ultrasound is really good at detecting or at helping to diagnose that someone has blood in their belly. Question about renal abscess. So renal abscess is, again, if you're concerned about it, you might do the renal ultrasound, and if you see something concerning for abscess sitting against the wall of the kidney, you see a hypoechoic kind of mixed, dirty looking signal against the kidney. Absolutely, that's a really suggestive finding. It's not a common indication. It's not sufficiently sensitive that if you don't see it, that you can say, there's no renal abscess. It is something that you could absolutely possibly see. I'll say that similarly, pyelonephritis, the most typical finding on ultrasound for pyelonephritis is just a normal exam. If it's really advanced, you might start seeing some that the calyces all look a little distorted or a little more hyperechoic than normal, but that's really in a pretty advanced pyelo. It's not the ultrasound is not great for pyelo in general or perinephric abscess. Does that answer the question? Okay. Any other questions?
I know we're talking about fasting, but do we necessarily need to fast the patient for a whole 8 hours before we do a KUB scan?
Do you need to fast the patient for multiple hours?
Yeah, because it's one of the reasons why we keep them long in our EDs to wait for a scan.
Oh, I got you. Yeah. So
8 hours.
Yeah. So the way that I think about using the FAST exam. So the true indication for the FAST exam is a patient with unstable vitals and blunt trauma. That's like the core indication for the FAST exam, because the question you're asking when you do the FAST exam is, does this person have blood in their belly or in their pericardium where I need to get them surgical help immediately? In terms of the waiting on the FAST exam, typically the indications to repeat a FAST exam are if the patient's status changes, like if they when they came in, they were stable, or they came in and they had a negative exam, but then something changes, I would repeat the FAST exam. If I had an unstable trauma patient who I couldn't send immediately to the OR and just had to sit with them and resuscitate them, I would repeat the FAST exam maybe after 30 minutes or an hour with vital sign changes, because you have to have a half a liter of blood approximately in the belly before you're going to have a positive exam. It may just be that there wasn't enough blood there yet to make it positive. So a repeat exam absolutely can be useful. In terms of doing it 8 hours later, I don't know any specific data for that, but the indication to do it in my mind is if the patient has changed, if there's a change in their status. And it's worth noting that, again, and that the FAST exam doesn't find all intra-abdominal injuries. It only can find blood in the peritoneal cavity. That's the one thing it's really good for. It doesn't find small bowel injuries. It doesn't find even high-grade splenic lacerations or liver lacerations if they don't, if the blood doesn't then get out into the peritoneal cavity. And it doesn't find anything in the retroperitoneum. So it has limitations, but it is good for one specific thing, and that is finding blood where blood shouldn't be in the peritoneal cavity or in the pericardium. Like that's really it's the thing it is really great at. Does that answer the question? Does that answer the question with too long of an answer?
No, because we haven't done fast exams. What I meant was because when we need ultrasound scans for acute abdomens and those renal colic, the sonographers will always ask us to fast the patient for 8 hours before doing a scan.
Like I'm sorry, that the patient can't eat.
Yeah.
Oh, I'm sorry. I heard fasting, and I assumed you meant the fast exam. I'm so sorry.
Do they necessarily need to fast for a whole 8?
So for an ultrasound exam, I don't know of an indication that they need to fast to be ultrasounded. No, that is not the case. It really shouldn't impact this particular exam. I will say, I don't know if there's going to be a talk later on the aorta and doing aorta scans. Scanning the aorta, it can be complicated by bowel gas. And so it's usually easier in someone who hasn't eaten recently, but it's not a contraindication to doing it. It just may be that like you put the probe on their belly, you see absolutely nothing because they're just full of gas. And usually that's more than that, and that is more common if the person has eaten recently. But to do the exams that we talked about today, particularly the bladder and ultrasound exams that are on the belly, there's no need for them to fast prior to doing it. Does that answer the question? Okay, great. Perfect. All right, any other questions? Awesome. Well, I really appreciate you all making time in your obviously busy day to come to this. These are the two places that I pulled the representative images from. Literally, if you go to that POCUS Atlas page, it will have all of the images that we discussed today. Again, a really great resource. And then the Wikiem page, also very helpful, and has a nice description of hydronephrosis grading if you're ever kind of in doubt about how to think about that. This is my email. If you have any questions that come up later, you want to discuss any ultrasound cases,